So today's topic of discussion is breaking bad news. And I think that's one topic which is really one of the very sensitive topics. And usually we are not, very well trained into doing this. So as a result, a lot of violence and litigation and aggressive reactions we receive from the patient party. And this is again a skill that can be learned, that can be taught. So as a trainer, I think each one of us should know, because this is something you will be asked by your, the hospitals, whoever will invite you for conducting any programs, to do this activity for the doctors and nurses and for other paramedical staff. So if I may start by asking, what do we mean by breaking bad news? Or what is bad news rather? What is bad news? If you write in the chat box, what do you think? What is bad news? So I think Dr. Shashikala and Dr. Dipti has joined just now. Just to tell you, we have started with the topic of breaking bad news, and I've just put a question to everyone that what do you think is bad news? Okay, so Dr. Monica says something that's life-threatening. Okay. Dr. Ramya says any news which can upset the listener. Yes, completely agree. Dr. Gaurang says it's a subjective definition, but most common is something which the person would not have a pleasant feeling listening to. Absolutely. Okay, Ritika says when the patient's condition is critical. Yes, that's very common bad news when we announce. Life-threatening situation of the client. Yes, Vanurika, you are right. That's very common again whenever we have a poor prognosis. That's a bad news to the family. News which is not favorable for patient party, and it's sad news. Yes, I agree with you. Dr. Birender says news which is against the expectation of the patient, news regarding poor prognosis or death, or a mishap that happens during the course of care. Absolutely. So all events that can, compromise patient safety and continuity of care are definitely a bad news to the patient and the family. Life-changing diagnosis. Absolutely. I think you all are, right. If we collectively see what you all have said, actually is the true definition of bad news. And that's normally what we think, that anything that is severe or critical is a bad news. But if you ask me honestly, even telling somebody that you will not be able to conceive or you will not be able to have a biological child comes as a bad news. I remember, a boy was brought, a medical student he was brought by his, parents to me, saying that probably he's stressed out because of the exams and studies. So, he requires little help in terms of your guidance and counseling. If you could speak to this child and, counsel him and calm him down. So when I went into the details, collected history, and he was a clear-cut case of OCD. That child had OCD, and actually those symptoms were there right from childhood, but then it became a full. Somebody's mic is off on. If you can, Namrata, I'm muting your device, please. Yeah, thank you. So when I did the whole discussion and found out he was a clear-cut case of OCD, he had those symptoms even before, right at the school age, but they were probably not that seriously identified. But this time it became a full-blown kind of a disorder. So when I announced this to the parents, it came as a shock to them. Now imagine the parents' state of mind, who after a lot of difficulty could help their child, get admitted into a medical college, and they were very happy, very excited. And then suddenly they see their child, going into something like OCD. It was a real shock to the parents. They were not able to believe. And they were actually insisting, ma'am, for a few days, if you could continue calling him, I'm sure he will improve, and then he'll be able to go back to college and attend his classes. So their concern was still that he should be able to go back to college and start his classes and behave normally. But as we all know, OCD takes time to one takes time to recover, and you require medicines and you require proper intervention. So simple diagnosis like this, no, it's not a simple diagnosis, I'm sorry, but diagnosis like this also can be very shocking to the parents. I've seen parents fainting in my clinic. My husband is an ophthalmologist and we have a joint clinic. So I've seen parents fainting, mothers literally fainting when they get to know their child is amblyopic or high myopic or hypermetropic. I mean, they're just going to disbelieve, and they would cry, and they'll say, no, aapko koi galti lagi, aap dobara check karo. And honestly, a lot of them will go for second opinion because they will not be able to believe that, oh, my child has this visual error. Although we all wear specs and it's so common, but when it comes as a first news to the parents, it's very shocking. It's very, very shocking. And trust me, I'm talking about almost like 20 years ago when my kids were very, very young. So I had cough and pain in my lower ribs for a couple of days. So my husband took me to his friend, okay, and he examined me and he said that get the X-ray done. And meanwhile, I'm starting some antibiotics simultaneously. So let's see, have a look at your X-rays and then decide. So when he saw the X-ray, he identified some shadow in the lower lobes on my left side. He said it's a shadow. We still don't know what it is. Let's start with the antibiotics. If everything goes well and if the X-rays come out clean after say 3 to 5 days, I think we are good to go. Otherwise, we'll have to work and look for the cause. And one of the possible causes is tuberculosis. And we all know tuberculosis is so common. Among healthcare professionals, it's very, very common. And earlier it was a disease of poor, but now it's a disease of a middle class. We all know this. Trust me, those 3 or 5 days till I had my second X-ray done and my, final this thing, my whole world turned upside down. For me, the questions were, who will look after my kids? Can they sleep with me? Can they eat with me? Can we share the same plate? Can I kiss them? Can I hug them? Where will they sleep? Where will I sleep? I mean, honestly, if you really want to see the impact of any illness on anybody, just go through it and ask yourself. It's very, very, threatening, very, very sad. And that gave me an idea that though I know tuberculosis is curable, you just have to take treatment, you can lead your normal life, you can eat your normal food. But the kind of questions I had, though I knew the answer, they were more like rhetorical questions. But once you are in that situation, probably you are able to, feel the pain or feel the heat. So I think we'll do a small role play. So I'll be putting you in pairs. And I will prefer, doctors not to play the role of breaking bad news. I would want non-medical professionals to play the role of breaking bad news. There's a reason. There's a reason that I'll share with you. But I'm just sharing the case with you, that the case that we are going to, practice. A very simple one. The idea is that just to understand the challenges of breaking bad news. Okay. So this is the case. So imagine your patient is a young man or a woman with a diagnosis with pancreatic cancer. Now you have to break this news to the patient, and the all investigations have been done. Now you're very sure of it. There's no doubt. But you need to now break this news to the patient. So we can do it this way. How many of us are there? We are 11 of you. So I can even think of making one as a family member, because it's equally, painful to be the family member. So I'll put three of you in one room, or maybe in two cases, I will be putting four of you. So one patient, one doctor, and two attendants, and in some cases, one attendant. So you get total 10 minutes time to practice. And then we'll having a role play in the main hall where everybody will be able to see. So the idea is, see how it is done, and then what challenges do you experience, when you have to do it. So I'm going to create breakout rooms. I'll create 3 breakout rooms. Okay. Uh, and then only request is that people who are from medical profession avoid now becoming the doctor. Let the non-professional be the non-medical professional be the doctor. Is that okay? Are you all okay with that idea? Okay. Okay, I think in each group we have someone. So please join the group. Yeah. So Dr. Dipti, are you having some challenge in joining? Dr. Dipti?
Yeah.
The thing is, I have actually created 3 breakout rooms. So they are practicing breaking of bad news. So I had assigned you group 2. Are you comfortable joining that group?
Yeah, fine.
Sure.
What do I do for that?
Did you get that message of joining?
Yes, I had got that 4 boxes had come where it was written chat. That,
Yeah.
but
So
that was on my mobile because I was on way home and I got stuck. So now
okay, I think I'll assign you. I'll assign you once again. Give me a second. So I'm sending you to room number 2.
fine.
3 में भेजती हूँ 3 में. I'm sending you to room number 3. So you must have received a message. Please join. So those who played the role of the doctor breaking bad news, I want
Me,
to
ma'am.
ask. I want to ask all of you who all were playing. Namrata, you,
Yes,
Banure,
Bhanureka, me, ma'am.
and Ritika. Am I right?
Yes,
Yes,
ma'am.
Okay. So how did it feel to be there? One by one. Maybe Bhanureka, you can share your.
Yeah, it was quite stressful for declaring such a bad news, ma'am. So I just initially I doesn't know how to disclose news. As though I got all the investigations, everything is ready, and it is confirmed that she is in the last stage of cancer. But still, it was what to say. It was I felt very bad to disclose this news to the patient.
So Namrata, if I may ask you, what questions were on your mind, or what were your concerns when you were
ma'am,
breaking this?
my concerns were that along with breaking the bad news to patient and their family, I should also be with them, like in the sense like I should show them, yes, I am with you, and yes, let's together plan for like whatever better we can plan for future, like whatever the stage particular stage has been diagnosed. I was with them to suggest them, yes, in future we will be planning so and so things for patient. These things will be there. There will be certain lifestyle changes and everything. So what
So
the thing I have.
Namrata, 1 second. Try to focus on what did you experience being in that chair, because breaking of bad news is done by doctors.
Yes,
So are you able to, it's more like, creating empathy for them.
yes,
That are you really able to think like this, the way you are saying that I was trying to, see how I can help my patient best.
yes.
A lot of time the situation is not all that simple and easy where you start looking at things from the patient's perspective. As an individual, what did you experience? What were your doubts and concerns about your ability? I'm trying to understand that.
Ma'am, yes, I was I was actually worried with the things that am I giving them the right advice, or am I I had a certain data with me ki, हाँ, yes, yes, these tests were done. So trying to be empathetic, I knew what their worries were. I was feeling that, but at the same time, I was also worried within that. Will I be I should be able to provide them what they want. So that worry was there inside within me, which I was not able to show them because I had to be confident in front of them that yes, I
Absolutely.
am giving you solution. But within, I was also, worried and equally sad for the patient, but I was not able to show that thing to them, that particular phase to them.
Absolutely. So Ritika, if I can have you on the camera, if you can have your camera on. Ritika, are you there?
Facing some connectivity error. I guess she's not there right now.
Oh, okay. Okay, so by the time she joins, now I want to ask all others who are actually medical professionals, but I deliberately made them, play the role of patients or patient's family. How did you feel being there? If I may ask, who all played the role of a patient?
Myself, ma'am. I mean, patient attended, sorry.
Pooja, Gaurav, we had 4 patients? No, 3 patients.
Monica,
Patient.
ma'am, Dr. Monica.
Monica. Okay, Monica was the patient. Pooja, you were also patient? And Dr. Birendra, you were patient. Okay. So Dr. Birendra, how was it to be on the patient's place? What emotions did you experience?
First of all, even though this was a simulation,
Mm-hmm.
I really was not able to imagine that I have this. I knew that this is a task. First of all, the conscious mind knows that. But still, when I was trying to be a patient, it was, I cannot explain. It was like a very frightening thing. So when the person was telling me, it was like he's talking about someone else. How can it be me? And I felt like this cancer is on top of me, but not inside me. So I was not able to understand. felt very weak and vulnerable and little frightened.
We don't even want to imagine that we have something like this.
So I can't find that one word, but yes, it is the bundle of the words that first of all, it's not me. So it felt, I was feeling like my body has defeated me.
Mm.
Why me? That kind of thing. And initially, it's like, okay, I'm listening, but I don't think it's me. So denial and fear.
Absolutely. I think that's very, very common. That's very, very common. So Pooja, you were patient in another group, I think. What did you feel being a patient?
Very similar to Dr. Virendra, what he said, no, like the moment it came, like there was immediately like, oh God, like what kind of a situation it becomes for, because if we were doing it's a role rehearsal kind of a thing. That I had a mother there, I had a sister there, and all of us there. So it was just like, like how to deal with this situation, which is the immediate thing came, and the questions that I was asking was something which just came out of like, how can this happen to me? These kind of things and all. As a young person who's getting all these things, immediately these things comes in. If we are following a routine, all these things, and so all that thing was coming up. It was just like unimaginable situation altogether.
Absolutely. I know role play as such is not a very natural way of experiencing the right emotions or the true emotions, but I think that brings us some closer to the reality. At least some feel we do get.
I can share some of my own personal experience, which I went through.
Sure.
It was 5 years back, and one day I felt that I've got some lump in the breast. So the next day itself, मतलब वो evening में अगर feel हुआ तो सुबह तक काटना वक्त कितना मुश्किल होता है, only I know. So morning we went to the chief of IRCH at AIMS, chief of the Cancer Rotary Hospital. He examines and that he just wrote down query CA breast.
Oh my God.
This was 5 years back. I lived through that, so I can share this coolly now since it's behind me. So the first thing was total numbness and dragging my feet, and he wrote mammography. So it was total numbness. So me and dragging my feet with my husband, I'm sure he must be going through. My husband lost his head, not lost, but he had got his mother treated for CA breast 20 years back. So I could see what he must be thinking and what I was thinking. Immediately to my mind was, my God, my children are so small. So dragging my feet, it was like a dead body walking to the mammography center. It's very crowded, and I was made to wait because the consultant was occupied with other patients. That 1 hour that I was sitting outside, I was just crying. You are lost. And I wanted to reach out, but I didn't want to reach out to anybody till I confirmed. So I think I write out something to my colleague, somebody who will not be emotionally connected to me. That, okay, I'm not going to come for work, and this is what I think, and I'm getting myself investigated. So obviously, after that, I was just me and hugging myself. And when I got the mammography done, I was told it's all clean, nothing to worry about it all. So within those 2 hours, I lived through this feeling of being told that you have a CA to coming out clear. So I can at least share my experience, what I felt as that patient when the news was open to me.
Absolutely. So it's quite similar to what I shared just now about, being diagnosed as tuberculosis. So for me, like, though everybody knows it's a very simple and curable kind of a condition, but just the doubt that, okay, I have this and all, what implications it will have on my life and my kids completely, derails your thought process. So I think many of us may have gone through something like this when we are diagnosed.
Like,
I want to share one thing.
Yeah, sir, please go ahead.
I was in my 10th standard, and I have been throughout my school a very bright student, fortunately. And, I used to be present every day. And, I suffered, I think it was at the end of the, it came out to be just an allergy to the coal or say some pollutant. So there was some kind of asthmatic attack. But for 6 months or a year, I was very breathless. I was not able to sleep. And this is, of course, I'm talking about 25 years ago or something. And I didn't have, I was definitely only in 10th. And, I'm going to this doctor. He says, my God, the WBCs are so high. And he's not able to sleep. He puts me on steroid, and I come back to my school and start reading my biology book. Then I go to my library, I take out, because I had read that, WBCs are high means it can be anything. It can be cancer, of course. So I kept reading and diagnosing and quietly and not talking to anyone with a lot of responsibility. So I don't know, at various stages in various age groups, patients, everybody has a life. So this is why me and how, and this is wrong, and this is a mistake. And let me escape somewhere to an ideal world. The patient thinks to just go away from there. So fortunately, it wasn't that, but yeah.
I know, I completely understand. And I think that period when you are not completely out of it, it's very, very, troublesome and also very, anxiety creating period. I absolutely agree. Yeah, Dr. Gaurang, you wish to say something. Please go ahead.
I think, yes, ma'am. Like, I'm breaking this for the first time with public platform, but getting out of something is still, I don't know, but facing the anxiety every single time is tough. Like what happened is I'm a myo with astigmatism. So every 6 months or 1.5 years, I go for my checkup. Last checkup I had done was in first year. I mean, back then I'm saying. And then after some time, when I just started my third year ophthalmology, I got my eyes checked in my hospital, and everything was fine. And it was just the beginning of third year opthal. And then the ophthalmologist told me I need to do an indirect ophthalmoscopy. So I was like, I mean, being a third year student, just a beginner in opthal, I had no idea what indirect ophthalmoscopy or what it is meant for. Then I said, okay, jo bhi karna hai karo. And then later she came and she told me, you have stage 2 of hypertensive retinopathy. I'm like, I'm sorry, what are you actually saying? I have no symptoms. I mean, honestly, I have no symptoms for hypertensive retinopathy. Now, every year, twice a year, 6 monthly ones, I am forced to go to an ophthalmologist to get my eyes checked, and I'm on lifetime antihypertensive medications with the fact that I'm just 24. I mean, I just turned 24. Back then I was only 19.
Oh.
Okay. Then they told me that you're young hypertensive, so you have to be subjected to a lot of tests, because hypertension in the old is like stress related, but hypertension in the young is not. They poked me multiple times. They've done all types of scans that they had to do to rule out every single cause mentioned in the textbook. Finally, they found out it's renal artery stenosis. They got it rectified, but still it had rebound problems. So I'm still continuing to have hypertension, and I take telmisartan amlodipine combination every day. The fact is, when they told me that they need to subject me to a series of tests, the first thing that came to my mind was repression. I think that was my defense mechanism. I think I was not in denial. I didn't want to hear the fact that I'm sick. People came to know, obviously it was my class professor, and it just spread. And people coming and showing me sympathy, I hated that fact. I don't know, I left everything. I told my mom and dad that before you guys subject me to any test, you're going to take me to a trip somewhere. I went to Goa. But that was my I think I was lucky enough to ask my parents to leave me to go to Goa as well. But then, yeah, that was the way I reacted. Now, every single time I go to ophthalmologist, she does indirect ophthalmoscopy. And by the time she writes it, my heart beats like close. Is it still stage 2? Am I going to become blind someday? Am I going to progress to stage 4? Because I really don't know what is happening. So I think when she just told me bluntly, I'm not blaming, but she could have made it somewhat better is what I felt. But she was very blunt in telling me, Gaurang, watch this. You have hypertensive retinopathy. You being a medical student, you don't know. I'm like, I'm sorry, me being a medical student does not entitle me to know everything. And specifically not something that's wrong with my body. So it was the hardest thing in my life.
Absolutely.
So that's
I think all of us have that means experience something like this, and we can actually empathize both with the doctor who has to announce and also the patient who has to face it and the family who has to hear and manage everything. So I think this is one topic we should definitely learn, understand, discuss, because more we discuss, more slowly we'll learn how to really deal with those situations. And if we can handle this particular part of communication with the patient and the family, trust me, a lot of violence and litigation can be prevented. if we know how to actually manage it effectively. Sometimes we don't do it in the right way. Sometimes we are not in the right frame of mind. Sometimes the circumstances are not okay. Sometimes everything happens so quickly that things are not in your control. But if you are mindfully able to, tread this road, you are able to actually prevent a lot of violence and litigation that can happen against us. So let me quickly share the screen with you and share some notes that I have on my mind to discuss with you, and also share a protocol that I would recommend, but then at the same time, you can, design your own way of communicating, but then this will give you an idea how we can go about doing it. So I'm sure you got to understand what challenges you would experience if you have to do it. We say that he or she did it, insensitively or in a more blunt manner, but actually it's very tricky. If you don't tell the truth, like for example, when Dr. Dipti said that he wrote query CA breast, had he not written, unfortunately, if that was the case, then we would have doubted his competency. That he didn't even write it, he was not even sure. So that means I probably could not even diagnose. So that's the trick now. I mean, if you write, there's a risk because the patient can read because they're educated. So that affects them, because the moment I get to know I have CA breast or CA uterus, that's going to affect my psyche. And I clearly remember one case, how knowing affects a health is, a patient was brought to me by her husband. She was a case of, CA. She got herself treated, got the chemo done, everything done, and she was doing very well, leading a very nice, cheerful life, and everything was fine. So one fine day, she had to go for her follow-up. So she got her, blood sample taken, and then from there, both husband and wife, they went for movie. They were like almost my age group people. So they went for movie, and the next day, a movie and then restaurant, and had their dinner and came back very happy, very cheerful. And then the very next day, they got the report that the reports were not okay. The moment this lady got to know that my reports are not okay, she was on bed. So that's the impact of knowing. If you don't know, probably you will not feel that bad. But once you get to know, your mind and body starts, So it is challenging for the doctor to do it. It is equally challenging for the patient to also, do it. So clinician perspective, we all know it's very difficult. It's not easy to, find words to express in the right way. Sometimes your words fail. Sometimes your tone of voice fails. Sometimes your body language does not go well with what you are saying. Sometimes you don't even know how my communication is impacting the patient. So it's a very tricky kind of a communication, and it requires a lot of understanding of human behavior, human reaction, and then how do you really handle those difficult situations. Patient's perspective, I'm sure you all have experienced being patients and you have seen patients closely. So you have an idea. For them also, it's not easy. When you're explaining them, things actually fly over their head. A lot of vocabulary is very unfamiliar. They're not familiar with, so they don't get to understand what exactly the doctor is saying. Even if they understand, there can be denial, there can be repression, like Gaurang said, that I just didn't want to talk about it. Or there was denial, no, it can't happen to me. Or there can be an anger, why me and why not somebody else? So it's a very mixed kind of a feeling. A study, very clearly showed that in 79% of the patients and 68% of the patients, families and the patients said the bad news encounter was suboptimal. They felt the physician was too blunt. Like, for example, this patient coming out and saying that you can't conceive. Sorry, this doctor coming out and saying that you can't conceive, or sorry, your child is amblyopic, or you have hypertension. I mean, simple diagnoses like hypertension and diabetes, which we distribute day in, day out, they come as a shock and as a blunt information to the patient because they are not prepared for it. They are not ready for it. Or there is a feeling that the place or the time was not appropriate. So usually we will do it if it is OPD, then we will start talking to the patient right in the OPD. There could be people who are overhearing your conversation. You may not realize that, okay, I mean, I need to have, provide privacy to the patient. A lot of times there are relatives probably who need not be involved in the discussion, and the patient does not want to talk about it. And we don't realize, and we talk in front of the patient's relatives or friends or acquaintances. Even sometimes timings may not be right. Maybe they have a marriage in the family. The child is flying out, or there's an exam, or whatever it could be, or like in many ways it could be inappropriate in terms of time. Then also patients got this sense that there is no hope. A lot of time when we announce there is actually a possibility of treatment, there's a possibility of recovery, but at times the way we come out, it may appear that there is no hope and probably it's the end of the world. And all of them said that they wanted the physician to balance sensitivity and honesty. So those who would say that it's important to tell them the truth in the right manner, in the right way, probably need to understand that yes, you need to be honest, but you need to understand how it is going to impact the other person. So I really need to balance both the things. What goes in, what the patient want and what they receive, there's a gap. And a study actually talks about this gap. Although most of the patients were very satisfied with the way they were delivered the news, but 57% of them wanted to discuss life expectancy, because the immediate concern once you are, you have accepted, the question is, okay, how much time do I have? What is going to be the quality of life after this, or what is the likelihood of progression of disease? But studies said that only 27% of the doctors actually did the discussion about life expectancy. 63% of the patient wanted to discuss the effects of cancer on other aspects of life. Again, probably sometimes we become too clinical to talk of the disease and its outcome and don't realize how it's going to impact the patient's life and require intervention. Only 35% actually got the complete information on this. So this we have discussed already. Bad news is anything that has serious and adverse event. I saw a new LinkedIn post. I'm sure some of you may have also seen this young boy who was diagnosed with diabetes, not just diabetes, actually extreme diabetes, something like 500 as blood sugar. At the age of 20, and then he said, for me, life ended for a minute there.
Yes.
Yeah, I'm sure you must have read that post given. I think this post really give you a vision.
I've seen a few days earlier.
Yeah. So
it was and all. Yeah, that story.
Yeah, and now he's been able to work on it and lead a happy life and balance. But the immediate impact is that it actually debackles you. It really takes you off your guard and throws you down. So it has definitely impact on the individual's life and future, and especially present. Why only future? It's present, I think, that gets affected, and it has indirect bearing on family and society. So it's not just about death or complication or or a death or complication or some a serious thing that has happened. Even diagnoses like diabetes, hypertension can be very worrisome. So we can empathize with Gaurav when he says that, I've been told that, okay, you have second stage hypertensive retinopathy. So I'm sure at the end, at the back of his mind, he would always have this, suppose if it deteriorates, then what the life will be. So it doesn't really have effect on today, but all on his future and other things. Yeah, Monica, I think you want to say something. Go ahead, please.
Yeah, ma'am, even I would like to share the incident, we also went through a similar situation. My mother-in-law, she was diagnosed with CA uterus.
Mm-hmm.
So we were not we did not want ki unko malum chale. So we told the doctor that we will try to convince her for the surgery. But please don't tell her. And once she's ready and she's put she'll be coming for the surgery, and then you can tell her. So that this incident I wanted to share. Not only for the patient, for relatives, I think it is more difficult, because then what happened before she was going for the surgery, the doctor again asked us कि आपने बता दिया उनको कि किस चीज की surgery हो रही है. So we told them कि नहीं, अभी भी नहीं बताया. So then doctor herself, she on the table, my mother-in-law was on the OT table, and then she told her before giving her the anesthesia कि आपको ये है, and even though it was just 30% into the uterine wall, but still we would want कि आपका uterus remove कर दें so that it does not spread and it becomes life threatening. So it was, ma'am, so difficult for us to tell her till the day of surgery कि उनको ये problem है. So we've been in
Now
that
you
situation.
see, we are talking about the timing. You remember, you saw that. Imagine the doctor announcing this to the patient on the OT table. So what impact it is going to have on the patient's immediate health condition, her, her emotional state, affecting her physiological, parameters. So
Ma'am, but the
again,
doctor was very nice. मतलब उन्होंने उस तरीके से बताया कि she did not, what I feel in that situation कि she did not like get
Monica,
that much
speaking, I
affected.
don't doubt her capability, but then
Yeah.
again, it
Yeah.
could have affected the patient's, immediate state of
Definitely,
health.
ma'am.
And that
Definitely.
would have complicated with the surgical, procedure. So that's
Definitely.
something that we really need to be careful of. So this is about, okay. So what challenges do you think the younger generation doctor experience? Because we see a lot of violence, a lot of aggressive reactions coming up, especially when they are, breaking this news to the family that patient is no more, or there's a complication, or there's a deterioration, or something has gone wrong. So what challenges do you think the younger generation experience? What do you say? Write in the chat box that what do you think? See, seniors, I think they learn by doing. They learn by making mistakes, and then from their own mistakes and by observing others, they get to know. But a lot of time, young doctors don't get to see, but they have to do this duty. So it could be, it could be actually very challenging for them. Am I capable to do this? Yes, that's a doubt they will have, but they will never be able to admit. They don't have that patience, no time. Yes, a lot of time, because they think what I'm saying should be understood as it is, and the other party is not able to see. So they lose patience. Maybe that's one of the time is another constraint. Yes, because it requires some time to let the patient and the family absorb, understand, ask, clarify. So a lot of time when you're overworked and you don't have time, there's a possibility that you may lose patience. What else? What else? Yes, younger generation is facing a patient and a family in this new era of customer-client relationship. Yes, the customer world, so they are more frightened or offhand sometimes. Absolutely, I think I agree with you that, and it requires training, it requires preparation, and we are not giving them any exposure in terms of their learning and training. Of course, Gaurang, I agree with you. They have fear, they are skeptical. One of the most common cause is the brain drain. Yes, because I know that's true. Then they tend to fumble, so their competence is always put on the table of discussion, and credibility is in question. And then there's a pressure from the seniors. Absolutely, I agree. Okay, you thought as a young patient. No, as a young doctor, I'm saying, Monica. Yes, listening is the skill required. Again, a lot of time we all are, mind readers. We jump and we interrupt the patient. Dr. Dipti says they're very uncomfortable as they are not trained for this, but end up doing it clumsily. Absolutely. And so I would not blame them for being, impatient or incapable of doing it, because we haven't done the competency building. We have not trained them. So it's something like if you have not taught somebody to fly a plane and you ask them to fly a plane, it's something like this. So a lot of it is because they have not been exposed, they have not been given any formal training, nobody has explained them, in a real situation, and they only learn by observing. If they have good role models, they will learn the right way of doing. But how many good role models do we really have? That's $1 million question to be asked. So this slide, maybe a lot of you may have seen somewhere being circulated. So they're carrying a dead body of a disease, and then they're carrying a banner in front of it. The banner says that this lady died because of the negligence of such and such doctor, and he or she should be punished severely. I'm really not sure if any error or negligence actually happened in the care, but definitely there was a communication gap where the family and the patient should have been, informed, updated, kept in loop, so that they were prepared for the eventuality. A lot of time we miss that opportunity of, preparing them. So breaking of bad news is one of the trickiest and most difficult communication. Most of the aggressive reactions you will see, they occur after the breaking of bad news, because it requires advanced level of communication skills. So you really need to be good at words. You really need to know what should be said. I think I told you, I did share this experience with you, that a young lad who was going to distribute his sister's wedding cards. Had I shared this with you? With this group? No. So this is a real case I'm talking about. A young boy who was, going on a bike to distribute his sister's wedding cards. He unfortunately met with an accident on his way and died on the spot. So his body was brought to the nearby hospital. Family was informed. Everybody came in. And then the family was informed that the body will have to undergo postmortem, because that's the protocol that we need to follow. Now, the family was already so, shaken with the incident. So they requested the doctors on duty that, do it as early as possible. First, they were requesting not to do the postmortem because it's a road traffic accident case. So what fishy are you expecting in this? But when the doctor said, no, this is the guideline and we cannot go against this, so you got to really, follow the protocol. So then they said that it will not be done today, it will be done tomorrow, because that hospital did not have the facility for postmortem. They had to call the doctors from the other hospital to do the postmortem. So they said it will be done tomorrow morning and the body will be kept in the mortuary. So with the hope that the medical superintendent will be able to, help them, they went to the medical superintendent and they went and requested कि sir देखिए आप already हमारी हालत देख सकते हैं. I mean हमारा तो सब कुछ एकदम खत्म हो गया, and then now this boy has to be, postmortem has to be performed. So if you can get it done today, please कर दीजिए ताकि हम आज इसको cremate करेंगे. पता नहीं अब शादी भी करते हैं नहीं करते. I mean, this was the discussion they were having. Can you imagine what were the words the medical superintendent said? And I'm telling you the real story. He said, मिट्टी है, चाहे आज करवा लो चाहे कल करवा लो. And what must have happened after it? You can well imagine. So you really require very advanced level of communication skills in terms of the words that you choose, tone of voice that you use, body language that you showcase, because anything going wrong communicates something very, very, different from what you want to say. Again, in another hospital, a child who was in the last stage of, cancer, they knew that the prognosis is poor. They were trying to intubate. They could not do it. They called ICU doctors to come and do it for them. So the child's family were all there around the bed or nearby. This ICU doctor who came in before doing the intubation, he started shouting at the relatives. क्या तमाशा लगा रखा है? चलिए बाहर यहाँ से, ये कोई खेल हो रहा है जो आप यहाँ पे खड़े होके देख रहे हैं? And he sent everybody out. He did the intubation. The child ultimately died because they knew that the child will not. So the family, who were very thankful to the doctors who were treating this child, next day they came in and they asked this doctor. He said, who was that doctor who came in to put the tube in the child? So he said, why, what happened? That we want to really bash him for the way he behaved, because the way he was handling them was not appropriate. So you really require to be sensitive to the idea. How do you handle those situations? Yes, Dr. Ila, you wish to say something.
My question is here, is this only the skills which is missing, or it is the intention, it is their own conscious of that particular person or doctor which is missing?
Absolutely.
I feel at times it is the conscious which is missing, and that is those 2% of those doctors, because of that. And when they are beaten, actually I always say when they are beaten, it is the, it is not the fault of the patient, it is always fault on the other side. Sometimes I really feel that actually.
I would also like to add
the incidents you shared.
Dr. Ila, I would not like to generalize, because see, honestly, a lot of time innocent doctors are also beaten up. I mean, I would not generalize this way, but I agree there is a lot of communication gap that ultimately ends up into a violent situation like this. Because I've seen very innocent doctors being beaten up for no fault of theirs. But yes, in lot of cases, I'm sure what you're saying from where it is coming, because you're facing it day in, day out. But the reality is there is a lot of lack of training, lack of understanding, lack of communication that is ultimately ending up into situation like this. So yes, there has to be an intention. But even, okay, see, though I do not endorse this statement, but a lot of time people say this, fake it till you make it. Though I don't endorse this, I am not the kind who would endorse this, but I still would say, if you don't know how to really empathize, at least showcase a humane behavior, a decent, dignified behavior to death or to pain or suffering. At least that as a human we can showcase if we want to do it. At least that can be shown. Yes, Dr. Dipti, I think you wish to say something.
I
Please
would
go
like
ahead.
to say, apart from the few lucky ones who are getting an opportunity to get trained into communication, to say 99% of the institutions and the doctors have no training. So where do they acquire the skill to how to handle communication? It is immediate senior, not even the consultant. Because by the time you become consultant, you have some wisdom in you. They are learning, PG is learning from SR. SR first year is learning from third year SR. So it is a lineup of inaccurate people doing this counseling. And this chain is continuing. So behavior is something we learn by observing others.
Absolutely.
Now that we are coming into this communication, teaching and skilling.
Therefore, Dr. Dipti, I think the role of role models also is very important. So very consciously, senior people have to remember that what I display is being observed by anybody and everybody. So I really need to be very responsible in the way I lead my team. So just by the virtue of your position in the system, you're leading people. People are observing your behavior. So one has to really, but of course, this is something one can be learned. So we need to sensitize people. We need to really help people see why they need to communicate more responsibly with people. And a lot of reactions come when we don't realize the impact it can have. In another hospital, I'm sure even, many of you may be knowing, because this case was right in news in Delhi also, and must be on the national news also. This young boy, he was playing with a kite and he got electrocuted. He comes, he's brought to the hospital. On arrival, they knew it was already a case of broad dead, but then the protocol is we always, resuscitate the child. They tried doing it 2, 3, 4 times. They did it there, and then they announced broad dead. The family accepted, agreed. They went out. Somebody near the gate said that go back and tell them कि एक बारी और करके देखिए शायद बच जाए. ऐसे miracles भी होते हैं कि बच्चा की जान वापस आ जाती है. तो आप एक बारी उनको बोलो दोबारा करें, जल्दीबाजी में मत करो. This family comes in and says कि डॉक्टर साहब एक बारी आप दोबारा करके देखो शायद बच्चा बच जाए. Now imagine जो denial हम बोलते हैं, ये denial यहाँ दिख रहा है ना? पर इस denial को मैं handle कैसे करती हूँ, that makes a difference. अब जवाब क्या आया आगे से, भैया डॉक्टर मैं हूं या आप हो, आप कर लो, अगर आपको मेरे पे विश्वास नहीं है. इमेजिन क्या हुआ होगा उसके बाद में. सो ये डिनायल, एंगर, एग्रेशन, ये सब कुछ होगा. आई नीड टू बी प्रिपेयर्ड टू डील विद इट. आई नीड टू नो हाउ टू हैंडल दिस डिनायल. डिनायल पे मैं गुस्सा या एग्रेशन नहीं दिखा सकती. डिनाइल पे मैं टिट फॉर टैट नहीं कर सकती, या मैं उनको इंसल्ट नहीं कर सकती. That denial also has to be handled compassionately. Understanding, young boy who was fit and fine, no illness, nothing, playing on the rooftop, unfortunately, got in touch with the cooler. That cooler had probably live wire running through it. Got electrocuted. Imagine. So what I'm saying that we really need to understand how we need to communicate. And then it's full of emotions. Anybody who is losing their family, anybody who has gone through it, you would be able to understand. You completely lose sense of direction. You completely lose touch with the reality. You just ask doctor, please save, please do something, please do something. So the emotions. So are we in that position to handle those emotions? And then there is emotional reaction coming from within, because we are being blamed sometimes. We are being targeted sometimes. We are being called, insensitive or blunt or incapable. So that insult also is creating a lot of, reacting emotions. So to hold them and not to, use them or to come them out is again a very big skill. So one has to be really good at language, communication, and then handling emotions of self and at others. So one really needs to be good at words, and that cannot happen overnight. It's a lot of practice. Handling emotions of others and then controlling your own emotion. So that's something that we really need to, regularly, continuously practice. So a word of advice that I would like to give to everybody who is in healthcare: please build good rapport with your patient. What I have seen, if you have good rapport with your patient, even if something goes wrong by mistake by you, patient will still tell you, you haven't done it deliberately. And sometimes even a simple case can turn into an unanticipated outcome. If you have been able to build a good image about yourself, a responsible doctor or a good doctor, trust me, the family will still come up to you and say, you haven't done it deliberately. But a lot of time when we haven't built any rapport, they have no idea about the way we are functioning and doing so much for the patient. We have not updated them, we have not involved them. And suddenly when we break the bad news, the assumption that they have in their mind that doctors are not sensitive, healthcare professionals don't care, they are not concerned, they are only here for making money. If it is a government sector, they'll say that government hospitals are run like orphanages, they're not sensitive. So those assumptions become true for them. I mean, they are all false, but then their vision, their perception is, and that's where they start blaming us. Yes, Dr. Dipti, you wish to say something, I believe.
Say, could you, how come that it is the people who are working in hospitals, the allopathy doctor, they are the conflicts are. Why don't we ever get to know about all those unqualified, unskilled, I may say quacks who are practicing everywhere and probably seeing lots of patients, and they may not always be very, very poor. They may be even middle class. We may get to hear that they have been assaulted by somebody or something. I think there, what you just mentioned, rapport, that is part there.
Absolutely. So that was the next slide I was showing, which I wanted to tell you. Creating familiarity with the patient and their family plays a very pivotal role. So it's always advisable to create familiarity. So people who are working in ICU, and if you have a patient for 2 or 3 days with you, if you do not know the primary caretaker, it's your loss. You should be knowing who is patient's attendant, rather you should be knowing them by name. The moment you call them, अच्छा नीरज जी के साथ आप हैं, महेश, अच्छा आपसे बात करनी है. नीरज और महेश बोलते ही उनको लगता है अच्छा डॉक्टर हमें जानते हैं, हमें पहचानते हैं. आप देखो, आप गाड़ी लेकर जा रहे हो, आपकी गाड़ी किसी दूसरी की गाड़ी के साथ अगर रगड़ खा जाती है, गुस्सा आता है, we come out with lot of anger. I've seen men coming out with rod and something that they have in their car. पर जैसे सामने वाले की हम शक्ल देखते हैं, अगर वो कोई familiar निकल आता है, कोई पड़ोसी है या कोई जानकार निकल आता है, will you thrash that person? Will you beat that person? Will you fight? No. Because familiarity plays a very big role in controlling aggressive reaction. Unfortunately, we hesitate creating familiarity. We think if we become familiar, we will become friendly. No. Being friendly, being familiar is different from being friends. There's a difference between being friendly and being friends. We are not being friends with the patient, but being familiar, being friendly, being nice, courteous, well-behaved, it actually protects us, because then they'll have respect for you. They are less likely to, assault or fight with you. And this is studies that say, it's not just me who is saying it. Then keeping the patient and the family in the loop by addressing their queries. So every time they come up to us, डॉक्टर साहब कितने दिन लगेंगे, आपको क्या लग रहा है ठीक हो जाएंगे, कितना खर्चा और आएगा, रिकवरी के कितने % चांसेस है. Please do not, shun them away. Sit and talk to them. Explain them. 15% chance है, 20% chance है, या इतना खर्चा expected है. Because when you address their queries, they have some information to think about. Then they will come up with whatever their concerns are. Regularly updating them. I think we are doing it in ICU. I don't know whether we are doing it in other care areas or not. but regularly updating them, keep them informed, because that's something that they want to do. And then involving them in decision making. For example, a patient needs to be put in the ICU, or needs ventilator, or needs a procedure, or maybe, endotracheal tube, or whatever. Involving the family will get you their consent, and also they'll feel, okay, we have been empowered with the right to decide. I remember my brother wasn't well, and he was in one of the very premier hospitals of Delhi. In the middle of night, my niece calls me and she says कि the doctor on duty says कि consent sign कर दीजिए, अगर जरूरत पड़ी तो हम इन्हें ventilator पे डालेंगे. And she was hesitant to sign because she wasn't comfortable with the idea of putting him, on ventilator. Then I spoke to the doctor. I said, if that's the requirement, you need to explain why you are saying that you need to put him on ventilator. And plus, if she's saying that I am around, and anytime if you want, you can give me a call and I'll come back and discuss and sign the consent. You can't force her to sign, because consent cannot be taken forcefully. It's a voluntary act of will. So, but he could not, convince her or talk to her. The moment I told in a firm voice, I said, you cannot force her to sign consent. If she's saying, I'm around, you can ask me, you can call me, you can show me his condition and then take a call. You got to, respect that request from the patient. So involving them, I think, is an important thing, which sometimes we think that's our prerogative and we don't like to, take them. Again, transparency and honesty plays a big role. When they ask questions, they want to get information. If you're promptly able to, give them information in an honest manner, in a transparent manner, that builds a lot of trust. I think that is one thing we are really now, facing a lot of, aggression because of this. And if you remember, I think I'll be discussing that in the next session, that is disclosure of medical error. A lot of litigation cases happen not because of negligence. It happened because the patient feels that I have not been given an honest and transparent, treatment. I have not been given the information that I should have been given. So a lot of time, the litigation or violence is because they feel that we have been given unfair treatment. Let's also understand one thing. When the patient is in critical condition or has a serious diagnosis, the family is looming under the greatest fear of life, and that is fear of death.
Fear of death.
Absolutely. So anybody's, state of mind would change when you are facing a situation like this, when there's a likelihood of death of our close one. And studies show us that we look after the patient, but we do not address the family's concern, because we do not consider as the beneficiary of our care. Let's remember, when the patient is in critical condition, it is the family who is taking care of everything, right from getting medicines, treatment, financial support, they looking after the patient, and there is a lot of emotional, backlog that needs to be addressed. And there are questions when you are able to handle, answer, address, that emotions get addressed. Now, in this situation, although the breaking of bad news has to be done by the doctors on duty or the resident on duty, what is the role of otherwise residents, nurses, and other paramedics? What do you say? What is their role? How are they supposed to be behaving? If you may write in the chat box, or if somebody wants to unmute. Yes, they need to be compassionate, absolutely.
Ma'am, in addition to honesty and transparency, it's also important for the consistency of information. So I have also noticed that what happens is one doctor comes and says something and another doctor comes and says, lungs तो ठीक है तो ठीक हो जाएंगे, but the ICU doctor says हाँ but वो critical है. So that becomes difficult. So it's also important that the other teams be on the same page and everyone
speaks the same language. Everybody, yes, yeah. There should not be any ambiguity in the messages that we give that can create confusion. Absolutely. So compliment the doctors, but at the same time not disclosing the information without the doctor's consent. Absolutely, Gaurang. The nurses and the other staff is not supposed to be speaking about the patient's condition But at the same time, I think understanding that can we fill in the communication gap, at least being compassionate, at least being considerate about them. So empathetic and should not disclose about the patient to others so that the patient should not feel bad or sad. Yes, at least ready to listen, at least ready to improvise, to help, to assist, to guide. Even that is something, a very big help to the patient and the family. And I think, especially in ICU, what I always say, that you may have seen a lot of time we know the prognosis is very poor. Probably sometimes it is last few hours or a day that the patient is going to, live for. So if you allow the patient and the family to even see the patient, that's also a very big help for the family, because probably this is the last few hours when they can see their family member alive. So being, more accommodating to the family's request to allow them to see. So when I say accommodating, I don't mean allow tens of patients attendants to come and see, but at least the immediate family members like wife, husband, children, parents, and also telling them, giving them proper guideline that you are not going to touch anything, or you're not going to, disturb the setup. You'll be allowed only for 5 minutes. Give all those instructions, but allowing them to see the patient is very important. I think they really are very thankful to the hospital staff when the staff accommodates their request on those grounds. What do you think is the normal or the regular behavior we all get to see? I mean, if you have seen, people behaving, if you could write in the chat box. So what do you see? A lot of time they are are they empathetic? Are they considerate?
Whose behavior, madam?
Staff, residents, nurses, and the other support staff, or the other.
No, ma'am.
No, they are not very.
Usually, on the other hand, I don't know. This is from my whatever I've experienced. I'm sharing that there are two extremes. Like there's always a mid-wavelength among doctors. Like most of them whom I have come across worked with, that they are neither empathetic nor do they gel well. At the same time, I've never seen them being arrogant also. But with the paramedic stuff, with the residents and with the nurses, I have seen both the extremes. There are really good people who are very empathetic, who communicate well, who have that patience, and extremely arrogant staff also. And I feel this is more common among the paramedical staff. I can give one example that so mine was the only government hospital, state government run hospital. So in the entire union territory of Pondicherry. So most of the autopsies, though Jipmer was there, most of the autopsies used to come here only. So whatever happens said and done, it is a dead body, and it is our duty. It is a duty of the paramedic staff and the concerned department to dispense the body off in an aesthetic appearance, so that whatever cremation rites, rituals have to be done, they are done in a good manner. But most of the time, I have gone on rotations to forensic medicine 4 times because that was my elective major. Which I chose, and it was so bad to see that the paramedic staff working there actually demand money, saying that we take efforts in trying to make the body look good, so you are bound to pay to us. And even if we take the chance to report this, we are just muted. You can't speak a word. They're like, you do your work and you get lost. But that kind of behavior, that kind of attitude actually pulls in more trouble to the entire department and also the people. Because I think the very basic thing what we learn in anatomy, the very first year of giving respect to the cadaver is not being followed at the end.
Absolutely. So true. I think I completely agree with you. And that's the reality of many hospitals. Many hospitals. I agree with you. So I think we need to be more understanding and accommodating to the family's need, because they have already undergone a lot, and we need to be more empathetic. I think even during pandemic, we have seen, people overcharging for ambulance, for medicines, for whatnot. So I think we have, extreme variations on all fronts. So breaking of bad news should always be done by the senior most person present in the system. But incidentally, a lot of setups, it is the residents who are the senior most. So they are the one who are doing it without any training or without any proper priming. So I'm sharing the protocol that would help us in understanding how we can go about breaking bad news. There are many protocols available, but I find this one very simple. So I thought I'll share this with you. So there are 4 P's in this protocol. The first P is preparation. That is preparation of the physician, place, and patient. Second P is the performance, where you go about breaking the bad news. P is palliate, and then fourth P is planning. So when we talk about the preparation of the physician, it's very important to know every detail that you are going to, share with the patient. A lot of time we have seen, we got one test done, but we haven't got the report and we are not even aware that the report hasn't come. For patient, every single report means a final decision. So they may ask you, Doctor, uski report aa gayi. And then you say, acha, uske to maine dekhi nahi. So they will get a feeling that you are not in complete know of the case. Or they may, a couple of times we have also seen one patient's report getting attached to another patient's case sheet. And when we go and tell the patient that this is what is your case, and then you get to, oh, it was not your report, it was somebody else's report. So to be 100% sure of what you're going to share is very important. Before you make, before you break the bad news, it's important to make connection with the patient and the family. So straight away saying that, okay, you have this. Like, for example, you said, your doctor said that you have stage 2, hypertensive retinopathy. So maybe if she had started something like this, ki, घर में किसी को hypertension है क्या आपके घर में? आपके घर में किसी को हाइपरटेंशन है? सो मे बी यू सेड कि नहीं, मैं मेरे घर में किसी को भी तो नहीं है, मम्मी को या पापा को या फैमिली में किसी और को. सो व्हाट इज, इट्स लाइक starting from a small talk to a big talk. So you are building connection with the person. Then you slowly say, and then also, even if you're 100% sure, okay, ye lag raha hai, you would still not announce it in one go. Probably say, कि देखने में ऐसा लग रहा है, maybe we need to get another investigation done to be more sure whether it is, or maybe second opinion. But then a lot of time we just come out as a, in one go we say. So making connection with the patient is important. A lot of time patient will have a lot of questions to ask, especially when they are in denial or they are not very sure or they are not ready for it. Or if it's a young patient, or they are still not able to accept it. So be mentally ready to spend some time. We have seen people, doing it in corridor, or while at the bedside, or even in OPD, where you have so many other people around you and there are so many more patients to be seen. But I think all serious diagnoses should be done, announced in a manner so that if the patient wants to ask something or discuss something further, you should have enough time to deal with that. Interruptions like phone call, visitors, they really break communication. So this should be definitely avoided. I've written here, please do not delegate once again, because a lot of time we delegate to others. The doctor who is doing it or doctor who is treating the patient should be doing the breaking of bad news, because the complete case. So the patient would expect you to be, talking about the case. About place, we know in corporate sector, of course, now we have counseling rooms. Doctors even call patients and their family members to their consultation room and talk to them. In government setup, we know we don't have such arrangements, as such. But it's always a good idea to sit down at a separate place before you break the news. Breaking it in corridor or bedside in OPD, you are risking yourself. There are people who are overhearing your conversation. There are people who can actually instigate, they can unnecessarily interfere and trigger further complication. So ensure privacy. It's very important to make sure whether what you are going to say is what the patient wants to be shared with the others. Sometimes we are talking to the patient, there's patient's mother-in-law, father-in-law, relative, friend, office person with the patient. And we talk about their health condition, which later on can complicate patient's life. So ensuring privacy of the patient is very important. And involving somebody from your side, it could be like, if the patient's primary care is so-and-so, and is in good know of what is happening with the patient, or a social worker or a senior nurse, if you're able to involve them in breaking up bad news, that will help you in managing these situations, especially the emotional component can be, looked after by them. A glass of water or having facial tissues in your, consultation chamber or wherever you're doing counseling, it's helpful in showing your humane side and also comforting the patient. Before you announce, before you talk anything, it's very important to assess what does the patient know. So when you ask questions like this, what do you know about your condition? Or what has your referring doctor told you? Or what is your understanding? Why did we get this test done? Will give you a fair idea how much patient does really know. You will also get to know about illness denial. You will also get to know wishful thinking or unrealistic expectation when you will try to explore what is patient's idea about the illness, what is patient's understanding of the illness. So in case you are able to identify anything like this, I think that needs to be addressed then and there. Otherwise, it can complicate further. If there's any misinformation, that needs to be corrected right then and there itself. If you see the patient is not in the right frame of mind to receive the information, tailoring bad news is not a bad idea. And I think we do stagger the news in most of the cases where we expect any extreme reaction. It's very important to understand what is patient's information need. How much does the patient want to know? A lot of time you will come across patients who will say, Doctor Sahab, मुझे कुछ नहीं समझना, क्या बीमारी आप इलाज करिए. Even there, of course, we need to share some set of information, but then we understand patient is not, wanting to know more. But a lot of time patients want to understand what it is. Then also, are they ready to receive it? Especially if we are going to announce something for the first time and the patient is not expecting, then that means we really need to first check, are they really ready to receive the information? According to a study in UK, out of almost like 2,300 patients, 98% of the patients wanted to know if the illness was cancer. So like when we hide from the patient or when we don't tell them, we think they will not be able to take it or receive it or will not be able to accept it. The reality is most of the patients want to be clear about it, what it is. And 87% of the patients preferred as much information as possible. So a lot of time when we decide not to share the information with the patient, it may go against patient's interest, because it's important for the patient to know about his life and the time for, in case if somebody's, time is near. So when you're performing breaking up bad news, it's important to be sensitive, but straightforward. So any attempt to minimize the severity, by softening the blow can lead to vagueness and confusion. So like Ritika said, one person says he's critical, the other one says, देखते हैं शायद ठीक हो जाए, शायद improve कर जाए, शायद अच्छा हो जाए. So you are creating confusion. And then please remember selective listening, selective understanding, selective believing. These words will stay with the patient's family. Doctor साहब आपने कहा था बच जाएंगे. Doctor साहब आपने कहा था ठीक हो जाएंगे. So you really need to be very careful when you are using those words. The idea is promise less and deliver more. But of course, at the same time, you need to be sensitive, and understand that it's going to impact a patient. While breaking bad news, make sure that you use simple language, as simple as possible, because any technical jargon which the patient or the family cannot understand can create communication gap. For example, if you're saying the chances of survival are this percent and the patient, the family has not understood, it can create confusion. So please make sure that you use simple language. Let it be a dialogue. Usually we do breaking up bad news in a monologue manner. On the contrary, if you will make it a dialogue, for example, after you have explained about their condition, आपको समझ आया कि मैंने patient की condition के बारे में आपको बताया. The patient will say, हाँ जी समझ आया. आप बताइए आपको क्या समझ आया. So what is happening? You are able to see how much have they really understood. So checking for understanding is important. When you will have dialogue, you will have a chance to confirm. Also, if you will pause frequently, they will get a chance to ask you something, because when you're speaking, they will not feel like interrupting you. But if you pause for a few seconds, they will actually get a chance to clarify in case if they want to clarify. or if they have not understood something, maybe they'll ask you, Doctor, jo cheez ye aapne batayi, ye mujhe samajh nahi aayi, can you explain it? So using silence, appropriate body language as a tool to facilitate will help you create dialogue rather than having a monologue. We have discussed this in our second session. 7% of the communication happens through words. 38% is your tone of voice. So when you are breaking bad news anywhere, if you are sounding authoritative, frustrated, intimidating, rude, or being very, very, to the point, it can upset the other party. They may feel that we are acting insensitive. And of course, body language again plays a big role. So we need to be mindful of our body language. So nodding or, bending, leaning forward, these are the ways to communicate that I'm trying to connect with you. So some of the body languages that will help you in comforting the patient and creating good rapport. For example, greeting softly. So even if we know saying namaste, aiye baithiye, again a good way to start. Establishing eye contact. Why is establishing eye contact in this situation very, very important? What will happen if you maintain eye contact with the patient? Yes, Dr. Virender, very right. We can illustrate and draw and explain when we are explaining about their disease or progression, or absolutely right. Yeah. So why is establishing eye contact important, especially in this case? If you may write in the
it gives a sense of complete understanding to the patient that yes, we empathize with their situation, because it reflects our mental, our present state of mind then when we are breaking bad news. Second, having eye contact is a strong pointer to the fact that you know in and out about the patient, and you are just not simply rattling it out. You're 100% sure before you're breaking that bad news to them. I think it just builds a sense of confidence that they are at safe hands.
Absolutely, very right. Also, like Monica says, that I am listening to you. So when we are making eye contact, that shows that I'm listening to you. Dr. Virender says it equates with our confidence in what we are saying. Absolutely. And also making eye contact communicates that I am not guilty of what is happening in your life. We feel bad and sorry for what is happening, but we are not the reason for it. So therefore, it is very important to make eye contact to showcase that what I have done or what I have come up to you is with great confidence, with complete compassion and concern for you. But at the same time, I am not responsible for what is happening with your life. Yes, genuineness and trust also, absolutely, Ritika, that shows through your eyes. So you can communicate care, compassion, empathy through your eyes, confidence that what I'm talking to you is because I am in this position, so I need to communicate this with you. Again, maintaining posture. We have talked about posture a lot. It's very important. So anytime if you're sitting like this with your hands folded or standing like this with your hands on your side, this communicates authority or closeness or not being very cordial towards them. Leaning forward is a good idea. Listening attentively, yes, and you have to demonstrate that I'm listening attentively, not just listening attentively. Nodding whenever appropriate, agreeing to what they are saying if it is okay what they are saying. As I said, tone of voice plays a very big role, and then allowing the patient to express. If you will have dialogue, they will definitely have something to speak. And it's always good to allow them to speak, because you will get an idea about what they are thinking. Are they agreeing? Are they understanding? Are they understanding your point of view? Are they agreeing with what you are saying? Are they okay with the information? All that you get to see when you allow them to speak. And even if they are unhappy or aggressive or blaming, that also, gets shown when they talk to you. So there will be emotional reactions. I think being able to accept emotional reactions without being too reactive is a good way to allow them to express themselves. You don't have to reply or respond to everything that they say. Just by agreeing to, by nodding is also a good way to tell, yes, I understand what you are saying. Comforting the patient or the family with the right language, with the right body language, is definitely helpful. These are a couple of ways that you can start your conversation to kind of help them see that you are you are equally, concerned about them, or you are with them in this situation. So when you say something like this, I feel bad to tell you this, or unfortunately the report is not okay, or I'm afraid the news is not good, or the report is back, but it's not what we had hoped. So these all statements will help you communicate your, being with them. Then usually, whenever anybody gets to know about any bad news, it results in cognitive, behavioral, and emotional deficit. Suddenly, the person will feel thought block. The person will feel numb. The person will feel, I'm not able to listen and comprehend what is happening around me, because this has come as a shock or as a blow. We can't change the news, but we can either make the news worse, or we can give them some realistic hope. So it's very important to understand how is this going to impact the patient and how are they going to react. And we have to be, we have to be able to even handle that reaction very, very carefully and, in the right manner. So they may start crying, they may suddenly become silent, they may ask you, are you sure? They may be in denial by saying it could be wrong reports. Are you sure that these are my patient's reports? Or some of them may say, please don't tell my husband, don't tell my wife, or don't tell my family. So these are the usual responses of the patient. The psychological response that we all know to the condition is called DAPDA. So DAPDA is denial. Usually the person will be in shock and would deny the reality. Then they may become angry, unhappy, aggressive, revengeful, and blaming, because they are annoyed with what has happened with them. They're very, very upset because of what has happened with them. Third stage is called bargaining. So in bargaining, they try to see what can be done to reverse the situation, what can be done to improve the condition, what can be done to undo what has happened. So they'll try to say, कोई और इलाज हो सकता है, कहीं और ले जा सकते हैं, कहीं और ट्रीटमेंट हो सकती है, आपको कोई और मेडिसिन चाहिए तो मुझे बताइए, मैं इंतजाम करता हूँ. That means they are trying to bargain with you. And once the reality sets in, you will see them quietening. So that's more like a depression state where they'll become quiet and would just not, communicate. After the reality sets in and they get to know the reality, and when they start accepting it, you will see them accepting. So how do you handle these? It's very important to stay with the patient through these stages till the patient or the family comes to acceptance. A lot of time, these may not be in the same order. DAPDA may not be in the same order, but it's good to stay with the patient or the family till they come to acceptance. If you are leaving them in between, there's a risk that they may feel being unattended or uncared. And that at times can lead to, extreme reaction from them. So how do you deal with the different stages? Okay, so this is one study of 100 patients, diagnosed with cancer. 54% of the patient responded with shock. So shock is very common, which is more like denial. 46% reported frightened. Then 40% accepted the reality. 24% reported feeling sad. And 15% said that they were not worried. I mean, that shows that how common is denial and anger and, feeling sad and bad. So how do you manage these responses? Denial should be managed with information. So if the patient or the family is denying, it's good to show them their results, their reports, their X-ray report. They'll get to understand what you're trying to say. If you see them angry or annoyed, there's no need to react with anger and aggression. Please stay calm, listen to them, be supportive, and also, of course, asserting and empathy is also very important in anger. When they are bargaining, help them see the reality and use empathy and assertion to help them see the reality. When you see them depressed, it's important to show them the direction that they need to take, because at times they will be clueless of what we need to do now. What do we do now? So showing them the way forward. And then once you see them, following the directions and ready to take action, it's important to encourage them so that they can move on, then they can start working on it. I think empathy is a great tool, which we all have discussed earlier also. All those of us who have gone through similar situation would know what it is to be there. And once we use empathy, I think we can see their world from their eyes. We will not judge them for their behavior or rudeness or anger or crying, but we will understand that these are all just reactionary emotions, and we'll understand with greater compassion and understanding. These are some of the ways that you can create solidarity with the patient. For example, when they're very upset, so if you say that, yes, I can see how upsetting it is for you. I know you were not expecting this. I'm really sorry to tell you this, but then that's the reality and we got to really, accept it. So these ways will help communicate that you are understanding their plight and you are with them in their situation. Of course, for any clinician, especially after you have done it a lot of time, probably it would be different. But I would like person like Dr. Dipti to share her thoughts. So what it is to break bad news for you, Dr. Dipti, when you're doing it? If you may share your experience.
Just give me a second. Just give me a second. I need 1 second.
Sure. So what time it is? Yeah. What time it is?
I do feel scared still. I'm not comfortable. One word I can explain is I'm uncomfortable.
Uncomfortable. Absolutely.
So imagine, I'm uncomfortable.
So imagine if you have done it for so many years and you still feel uncomfortable. What about the young lads, young doctors? And it's very true. What you have shared is very, very true. And that's actually the reality, because you don't know what is going to come. How is the family going to react? Are they going to understand? Are they going to agree? Are they going to trust? Are they going to accept it? So I completely understand what you're saying, that it is very uncomfortable. Even seasoned doctors experience anxiety and tension.
I shared with you in my last meeting that experience in our obstetrics.
Yeah.
Unexpected loss of the baby.
Yeah.
Is something which hits you. You know that patient is sick, patient is in ICU for 10 days, it's okay. But what about when somebody is expecting good outcome, and at times even we don't get an inkling and some mishaps happen. Suppose an abruption, which can be predicted at times, and we lose the baby. So that I find very difficult. I wish there was somebody else to take the role of breaking the news and I could hide behind somebody. It is that.
Absolutely. I completely understand. So definitely, I think the clinicians are equally uncomfortable about the patient's expectations. There's a fear of destroying their hope. There's a feeling of inadequacy. Then one sometimes is not prepared to manage patients' anticipated emotion. I've written anticipated deliberately because these emotional reactions are bound to happen. So I should know I have to deal with them, and I need to learn how do I really go about. And sometimes if you have, painted a too optimistic picture for a situation and something goes wrong, it's very embarrassing to actually explain what exactly went wrong. So these are some of the ways that you can prevent those, experiences. Please give realistic expectations to your patient. Accept your professional limitation. Don't go overboard. Don't go beyond what you are allowed to do or what you're expected to do. Learn to control emotional reactions, because anticipated emotional reactions are going to be there. So we have to really smartly learn how do we really handle and control them. Keeping the family updated by keeping them informed about the patient condition is one good way to avoid extreme reactions coming from the patient's family. And last but not the least, document all communication. Whatever you communicate, please document. I think the thumb rule is communicate what you document and document what you communicate. If you can keep these two things in mind, you will not forget, because that is something that's going to save us tomorrow in the court of law. Once you break the bad news, the patient and the family fear that you are going to leave them. They fear abandonment. So it's very important to assure them that and actually we should not be abandoning them, but we should actually establish a plan of treatment. Treat their current symptoms, discuss their next treatment plan in case if they need to be referred. For example, if it's a patient of cancer, if you're not going to be treating it, then you're going to be referring, or you want to send the patient for a second opinion, or if you want to send the patient to a different setup. So you need to treat discuss the next treatment plan. They may want to come back to you for follow-up. for a couple of times till they become comfortable with the next doctor. It's always a good idea to, allow them to come for follow-up and establish the follow-up appointment and reassure them that they are not going to be abandoned. Whatever, referral you are going, if you can give them contact details of the person to whom they need to go, if you can write a proper referral letter, make a proper summary, and also if you can call in their presence to the doctor to whom you are referring, that's really, really going to comfort them that, okay, like I have been properly handed over to another doctor, so involving, potential source of support like family, friends, social worker, spiritual counselor, therapist is a good idea, because a lot of time doctors are not comfortable, meeting patients' emotional needs. I can't say I can't do it, so I can't do it. If I can't do it, can I make some arrangement so that somebody can fulfill the patient's need? That's the arrangement we really need to make for the patient, with the patient. Last slide. I think I've shown this earlier also. Disease and death are very scary. I think you realize it only when we experience personally. I don't wish anything of this sort for anybody, but at the same time, I feel that this is something that really changes our viewpoint about people, about illness and death. So this was in nutshell or in detail about breaking bad news. And I thought it's an important topic and we need to really discuss. Any questions about what we have discussed till now?
How do we know that a patient has accepted what we said? What is a checkpoint to know that our communication is complete? So,
see, one of the ways is, of course, your observation of the patient's, behavior. So, and that's why I'm saying, if you will keep it dialogue, you will get an idea of what is on their mind. Because the kind of questions they will ask you, the kind of statements they will make, you will get an idea whether they are understanding or not. Another good way is a teach back technique. I think we have discussed this earlier also. So whatever you explain, if you ask them, I hope it's clear to you. I hope you have understood. So if they nod and they say, yeah, it's clear to me. Can you explain me briefly what is your understanding of what I've explained to you? Just to make sure that a lot of
the way the aggression they show, we should show, or like, how do I arrive that she has accepted, the acceptance has come to them?
See, suddenly if they become quiet and they are not opening up, so maybe they are not showing aggression now, maybe they'll go out and they'll speak to their family and then they become aggressive. Therefore, I say doctors, nurses, other paramedical staff working, their eyes and ears of, hospital. They should keep an eye on what is happening in there, and they should be able to, communicate to the higher ups to be ready to deal with that. So anytime if you see any denial or aggression, don't leave it unattended. Talk to them, explain them, give them time. I think one thing that you have to keep in mind is if it is a danger to your patients, your safety, because a lot of time if they are, first of all, don't have too many of them together to break the bad news. It should always be like 2 close members or 3 close members. The physical setup of your place should be, it should ensure your safety. That point has to be taken care of. Anywhere if you see they are reacting aggressively, please move out of that situation, because you don't know how they might react. Out of anger, anybody can do something that they would not do otherwise in their senses. Have people around you so that your safety is ensured, but don't show them as a sign of power. I have security guards around me, I have my staff around me. That can trigger aggressive reaction. But giving them time, listening to them, understanding their point of view, and not actually arguing, but giving a justified explanation is a good way to, close it in the right manner. Don't leave it unattended. I think the biggest risk is when you don't close it properly, they'll go out and they may come back as a mob, and then you get into trouble. I think Dr. Dipti wants to say something.
I think this last part is the most difficult. I think even more difficult than breaking bad news. What when things are turning bad? You can smell that violence, that threat around you. Then how to react? I'm still not sure that if I'm put in such a situation, I'll be able to handle it properly.
So one is never go and break the bad news in an open area, and don't have too many people around. It's always good to say that I need to talk to you about, your patient, and immediate family members could come in so that we could sit and discuss. So have maybe 2 or maximum 3. Out of those 2, 3, please have a person with whom you have regularly been communicating, because that person will validate your statements. When you will say, I have kept you informed, I have kept telling you about this. So that will kind of, that person will be kind of spokesperson for you. You will also see some elderly people who would be nodding on your statements. Again, take advantage of that. They are the one who will align with you. They are the one who will actually help you mitigate this situation. Make them sit, talk to them, listen to them, allow them to speak. And then wherever it is appropriate, give facts and figures to help them see the reality. For example, they say, किसी ने हमें नहीं बताया, किसी ने inform नहीं करा. Rather than saying, कैसे नहीं बताया? आपको सुबह शाम हम बुला के बताते हैं. I would rather say, देखो आप गुस्से में हैं, मैं समझ सकती हूँ, पर मैं आपको केस शीट दिखा सकती हूँ कि सुबह और शाम दोनों टाइम हम पेशेंट के फैमिली मेंबर को बुलाते हैं. देखिए कल शाम को भी कोई विनोद नाम से थे, आपके कोई फैमिली मेंबर है? तो पेशेंट का अटेंडेंट कहेगा, हाँ वो मेरे चाचा का बेटा है, वो थे यहाँ पे, हमने उनको अंदर बुला के पेशेंट को भी दिखाया और बताया भी कि इनकी कंडीशन में ये चेंजेस आ रहे हैं. डॉक्यूमेंटेशन विल रियली हेल्प. Most important is don't react to the anger. Never do it in open. अपनी सेफ्टी ध्यान रखिए. कॉरिडोर में मत करिए, बेड साइड मत करिए, बिकॉज वहां पे कुछ भी हो सकता है. Always do it sitting. बैठा कर करते हैं, झगड़ा करने की एनर्जी कम हो जाती है. और मैं तो सिटिंग अरेंजमेंट के बारे में भी बताती हूँ कि यू शुड नॉट बी सिटिंग इन द कॉर्नर. आपका कमरा ऐसा है कि आपके पास एग्जिट के लिए जगह नहीं है. Not a good idea.
I
So
totally agree with that.
Preferably
I felt at some point of time I'll mention about this back door.
Yes.
But
counseling room should have 2 doors. One is for the patient to come.
Rename it as a safety door rather than a back door.
Absolutely. A counseling room should have 2 doors. Yeah. One is for the patient to enter, and second is in case if you need to exit.
Yeah.
I mean, these are structural, this is infrastructural. Then there should be a panic button also. You should have a bell so that the moment you feel unsafe. Plus, it's always good to have people around you, maybe your own people who would not speak unless it is really required. And don't have people who are anger prone, because they can aggravate. Maybe you can handle it well, but they are the one who will fuel the situation. And there's no need to react to everything that they say. A lot of time, what they say is actually right also. So you got to also quietly accept the reality. मुझे किसी ने देखने नहीं दिया, मैं 4 बारी गई, मुझे किसी ने देखने नहीं दिया. That could be a fact. So उसमें अगर मैं ये बोलती हूँ कि आपके पेशेंट को देखें, आपको पहले उनको मिलवाने दें, that's not going to help in any way. That's rather going to trigger further aggression. तो मैं मेरे ख्याल से अगर बहुत बारी वो कहेगा तो मैं ये कहूँगी, देखिए आईसीयू में नॉर्मली पेशेंट के अटेंडेंट को अलाउ नहीं करते बिकॉज कंडीशन क्रिटिकल होती है, एंड इट्स फॉर योर पेशेंट्स बेनिफिट. आई होप यू अंडरस्टैंड. सो not reacting to everything, but you really need to have a very good control on your temper. इसके पहले मैं ये कहती हूँ, रेपो बिल्डिंग अगर अच्छा है और आपने रेगुलरली अपडेट करा है, आई डोंट थिंक यू विल हैव टू फेस सिचुएशन लाइक दिस. ये 2 काम अगर आपने पहले कर लिया, रेपो बिल्डिंग अच्छे से कर लिया और फैमिली को रेगुलर अपडेट कर रहे हैं, then they will know, because when you update them regularly, allow them to see the patient. आप नोट करिएगा पेशेंट की कंडीशन अगर क्रिटिकल है, अपने फैमिली को अलाउ करा देखने आने के लिए, आप ऑब्जर्व करिएगा बाहर आते टाइम उनका हाथ ऐसे हिल रहा होगा, नीचे लटका हुआ हाथ होगा और ऐसे मूव कर रहा होगा, और या उनकी गर्दन ऐसे हिल रही होगी, indicating that they have a realization that the condition is not good. And that's very important, क्योंकि वो realization जब होना शुरू हो जाता है, then they get to see कि end is inevitable.
Another question I have is, many a times I have seen within my own circle also, patients accusing doctor कि इन्होंने तो वेंटिलेटर पे डाल के रखा इतने दिन, जान तो पहले चली गई थी. आते हैं
डॉक्टर दीप्ति, जो आप कह रहे हो ये बिल्कुल ठीक है, बहुत बारी हमें एलिगेशन सुनने को मिलती है और कई बार ये सच भी है, बहुत जगहों पे सच भी है, आई एम टेलिंग यू। सो होता यही है, गलती अगर कोई एक करता है तो हर्जाना हम सबको भरना पड़ता है उसका, चाहे वो किसी, हर कोई नहीं करता, करता कोई एक है। नाउ आई नो ऑफ अ डॉक्टर लाइक वेल नोन टू मी and unfortunately is no more, मतलब he would make the patient buy a medicine worth 400-500 rupees, 20 साल 25 साल पुरानी बात बता रही, और लगाना नहीं है, मेडिसिन वापस चली जानी है। कोई एक भी करता है, जब आपका स्टाफ, आपका कंपाउंडर जो है, आपकी जो नर्स है, जो आपका जो हाउसकीपिंग स्टाफ है, जब ये बातें जाकर वो बाहर करते हैं ना, it takes seconds to spread the news about it.
Yes.
So we pay the cost of everything that we do, good or bad. अब वेंटिलेटर पे डालने की जो बात है, आप में से कई लोगों ने पर्सनली एक्सपीरियंस करा होगा। चाहे वो किसी एक ने कभी करा होगा, चाहे वो टू अवॉइड वायलेंस करा होगा, चाहे वो टू मेक मनी करा होगा, चाहे कुछ भी रीजन से करा होगा। But then
I agree. What happens, though it happens once in a decade or once in 5-6 years, suppose there is an OT table death because of any complication. You take the patient, intubate it to the ICU, there after some time. So maybe this is also a variant of that. And I'm from a government where money angle is not involved.
Not involved.
Not to take the money,
but to diffuse the situation, to let the thing,
yes,
stagger the situation.
Yes. Now that you say it, I realize it. It does happen.
और जब पेशेंट के फैमिली को पता लगता है, just imagine this state.
Patient की फैमिली को तो, as you say, the way to know it is when somebody is gossiping outside.
करते हैं, स्टाफ करता है, लोग करते हैं।
But now what to do?
और कभी-कभी assumptions होती है, उसको फ्लेयर अप हो जाती है।
अब अगर ओटी टेबल पे पेशेंट को हो गए एनेस्थेटिक कॉम्प्लिकेशन, ठीक है, आपकी 10 साल में एक बार ही हुई, पेशेंट को उस समय अगर कहो हो गया तो भी मुसीबत।
तो इसीलिए मैं बार-बार कह रही हूँ कि अगर आपकी रेपो बिल्डिंग अच्छी है फैमिली के साथ, आपने कंसेंट टेकिंग अच्छे से करा है, ढंग से एक्सप्लेन करा हुआ है, the family has this trust कि you will not do anything wrong willfully. And अगर आपने रेगुलर, ये बड़ा रेयर केस है जो आप बता रही हो, ये होता है, ऐसा नहीं कि नहीं होता, बट जनरली जो डेथ होती है, आईसीयू डेथ्स होती हैं, या उसमें अगर हमने उनको इन्फॉर्म नहीं करा हुआ, प्रिपेयर नहीं करा हुआ, लाखों रुपया पेशेंट का खर्च हो गया और बाद में हम अचानक कहते हैं कि पेशेंट इज नो मोर।
अच्छा, मुझे एक और डाउट, एक और मेरे को जो एज आई एम हेड, सो जितने पेशेंट है, चाहे 50 भी है, सबकी पर्चियों पे नाम मेरा छपा हुआ है, कमरा मेरा है, बेड के ऊपर मेरा नाम लिखा हुआ है। आता है वो समझता है ये दीप्ति गोस्वामी देख रही है, अभी कोई तो देख ही नहीं सकती। फॉर एग्जांपल अभी अगर वेकेशन है तो मैं तो जा भी नहीं रही हूँ। Often I'm not aware my co-faculty is operating. I have no rapport at all with the patient. I may not have a rapport because everybody is.
टीम का नाम होना चाहिए, तो इसको चेंज करो कि टीम का नाम होना चाहिए। Maybe you are the unit head, but then the team name, so that
मुझे लगता है मैं सोचती हूँ कि हमें जगह जगह नाम ना लिख के we should just write unit 5, unit 4, something like that, so that you know that name. I mean they will come and they will look for you and they will seek all answers from you, and rightfully so.
Yeah, absolutely. Yes, Dr. Gaurang, you want to say something?
Actually, we had a similar issue what Deepti ma'am was just saying. So that is what we followed. So what happened after such an incident in the pediatrics department in my college, they totally renamed everything. So earlier there used to be pediatrics hyphen the unit head's name. They now changed it as pediatrics hyphen, it's which number unit 1, 2, 3, 4, whatever, hyphen the initial of the unit head. For example, if it's Gaurang Narayan is the unit head, it's GN or NG ulta, something like that, which is not pretty obvious to the patient, and patient has no, because patient doesn't know what DA is. Most of them think least in the government sector where problems happen maximum in number with regards to violence and all, they really don't understand what they think this just another code and they walk off. Maybe that might help.
So maybe you can try this. That's a good idea, I think. Yeah. So I think with this, we come to the end of this session and we have 2 presentations to be done. And what time it is?
10:40, ma'am.
So what do everybody say? Should we have it? Because I know it's very late for all of you. You need to take a call. For me, it's okay because it's daytime. No? Dr. Dipti says no.
No, I say okay.
Okay.
For me, it's okay because I've taken efforts in preparing the presentation.
So let's quickly. Maybe what we do, we have one present today and one next time. Is that okay? ठीक है.
Yes.
Because next time में सिर्फ रितिका है, तो रितिका के साथ सेकंड किसका है आज? डॉक्टर दीप्ति का. डॉक्टर दीप्ति आपका नेक्स्ट टाइम कर दी, चलेगा?
चलेगा.
ठीक है.
And next time is okay, Friday. Yes.
Friday. I think everybody is okay with Friday. तो Friday कर लेते हैं. ठीक है. So Dr. Gaurang, you can quickly, I'm giving you the right to share your screen. Yeah.
So if you all have downloaded the Kahoot app, are you guys able to see my screen?
Yes, we can.
Okay, 1 minute. Yeah, so you can use this code and kindly please use this code, enter this code and just click join a quiz.
I need to see where.
It'll just generate a code, ma'am. Just a minute.
Yeah.
Yeah, this is the code. It's a game pin.
We can't see your screen.
Not able to see your screen.
Oh, I'm sorry. Is the screen visible now?
Yes.
Yeah. Kindly use this pin to join a game. So it's a user interface wherein, just to quickly explain, I'll be creating a quiz. It can be a poll, it can be a team assignment, it can be anything. So then see, as and when people join, it gives me the name of the person. For example, Ritika has joined. So it's just telling me that one person has joined my team. Ramya ma'am has joined, Pooja ma'am has joined. So as and when people join, I get to know how many of them are joining, how many of them are actually playing a game. So as a person who's going,
I am not able to. I have it in my mobile.
yes, ma'am. You have to use the option called join the game.
Okay, enter pin.
Enter pin. Enter
This
pin.
is the pin, ma'am. 5021154.
Just let me.
I am not able to see the option. Where do I go to join?
Madam, you have to just click enter pin करके एक बटन होगा बीचों बीच में, उसको आप क्लिक
ये
करो.
वो अभी मेरा तो उसमें just 1 second.
Yes.
It's not loading actually.
It's saying, okay, my Kahoot, what it is. Honestly, I'm using it for the first time, so I'm not.
This is my second presentation with Kahoot. Like once we were hosting a quiz competition for our juniors. So we planned it back then. But there are a lot of recent research articles. If actually we go to PubMed, Diti ma'am, you've joined this one. So we will get to see a lot of research articles, which talk about using Kahoot as a teaching tool.
So where do you have to enter that pin? 1 second.
So currently 6 of them have joined. If maybe a couple of more join or you give me a green signal, I'll start the quiz. So there'll just be 5.
I am not able to, so let me not take everybody's time. So I've got this on the,
yes, ma'am, I'm able to see. I think that's not the open page, ma'am.
I'm not able to hear you.
That's not the page, ma'am, where you actually enter the code. Can you just close it and open it again?
Okay, I've closed.
Yeah, that enter pin, ma'am. Enter pin is the one where you have to.
But it's not giving me any option of entry.
You click it, it will give. You click it, it will give that option.
So what do I do?
Just click on enter pin and you can use this pin, ma'am, given here.
But there is no option join.
Or I can do one thing, ma'am. I can give you a link in the chat box. Maybe I should have thought of what.
502-1154.
She's getting that.
Okay. Yes.
I should be there anytime.
Yeah. Yes, ma'am. You've also joined. So I'll just quickly start. Just to brief, there are 5 questions. Each question has 1 correct option. You can feel free to choose whichever is right. So it's a quiz on healthcare communication. So which of these factors affect written communication of a doctor? Do you think it's the neatness? Do you think it's the spelling? Is the mood, or it's all of the above? Only 2 of them have got it wrong. 3 of them feel it's all of the above, while actually this is directly taken from the journal citation, which states that though spelling actually doesn't really matter. So of course, technically speaking, all of the above seems the right option, but spelling is never a matter of concern. That was a distractor here. So neatness becomes the best option in comparison to mood. So as you can see here, it was a quiz. So as a teacher or as a trainer here, where my participants are going weak at, or what is the distractor here, or how I can plan, my next set of subsequent questions. Equally, it is giving me the poll. So out of 5 people, almost less than 50% get the right answer, which means my concentration should be on those people who are yet not able to reach to that point. So it gives me instant results. At the same time, it gives a scoreboard. So it gives a sense of a feeling of a game to the participants. So for example, Banu ma'am, she has the fastest fingers. So, she's though Pooja ma'am and Banu ma'am, you've just answered one question each. Your marks are same, but since your fastest fingers, Banu ma'am tops you in the in the leaderboard. So it also instills a sense of a game when it's a quiz.
Somehow I've got logged out.
Can you just try to type the pin, ma'am? Rejoin.
Pin again. I mean.
Yeah, 502-1154, ma'am.
502-1154.
Yes, ma'am. So it gives you a sense of a game as well, and it kindles that interest among all the participants to come forward and play it actively. That who tops it and who comes first. Has it come, ma'am? Were you able to log in, ma'am?
Yeah, I was saying my net is slow. I don't know.
Shall I wait for you, ma'am,
Saying
for a
that
moment?
nickname is taken. So I'll put some other nickname.
Yeah. And this also gives an added advantage that whenever a new participant is joining, he or she can join from the subsequent set of questions. They might not be able to go to the first question, but they can start right from where I'm controlling the program. So it leads the controlling authority is on the trainer rather than much more on the participant. So you get to decide the flow of the directions. Shall I continue, ma'am?
Sure.
So the second question, which of these factors would affect verbal communication between a doctor and his patient? Actually, this is a picture of how verbal communication happens in Safdarjung. So all 5 of you have got the right answer. It's actually all of the above. So as we rightly see, now the leaderboard changes as and when. So now Pooja ma'am is top because she was fast in comparison to Banu ma'am. So next we move on to the next question. So what does being tactful mean? So what is tactful in a communication? All 6 of them have got it right. So actually, if you see here, the image is a distractor. The image that I added to the question was a distractor. So this is another advantage of using such platforms or using quiz as a technique where you can use audio visual aids to actually make it. It need not just be a question and answer session. It can be a video, guess the song, complete the meme, or anything. So you can make it as creative as it's possible because it gives you multiple options. So Ela ma'am is going to be on the top board. Let's see who tops it at last. If at all I get a chance to meet, then I definitely would like to, host you for a cup of coffee, whoever the winner is. So as a doctor or as a healthcare provider, what do you think taking constructive criticism means? Okay, this was another important question. Why I purposefully faced this question was normally the length of or the time limit for an ideal quiz is 20 seconds for each question. But again, there is an inherent bias because if a trainer like me sets such long options, it's very difficult for the participants to actually read through them to arrive at a final answer. Because I'm asking the best question, which means you also have to rule out the other options. So setting such a question is a bad example. This question was purposefully set to explain this to you that if you're having such a training program, you're not supposed to use such long sentences or try to cut them, and most importantly, there are certain basic rules of setting a question, one of which is a fact that all options of the 4 or of the 5 that you have should be equal in length. Okay, most of the time people end up guessing the longest option is the right answer, or they see more number of options, it's the right answer. So there you're playing with the mind of the participant rather than actually providing the content. This is again wrong. So these are all pitfalls of using quiz, which a trainer must know. Going on to the last question. When a patient party is fighting with your resident, all of the following may be done except. Okay, so this was trickiest of all question. The reason being that whenever a resident is fighting and a senior consultant is there, most of the times what you should not do is never take a side, which means indirectly one of the core rules of talking is the fact that you're never supposed to show yourself to be a diplomat out there. Okay, so diplomacy is never the key when you're trying to resolve disputes. It could be there internally, but never obvious to the patient party. So that's like a total no rule. So I think this is a final stage podium. At place 3, we have Indu ma'am. At place 2, we have Banu ma'am. And the winner is, I think, Pooja ma'am. Oh, Ila ma'am. So I think I wanted to just make use of this opportunity to tell that this is how actually cohort works. Let me quickly brush you through the presentation that I prepared. So asking a question has always been the best teaching tool. I think that's why all the exams and evaluations, Viva VOCs or whatever it is, even bedside teaching has been more of asking a question to anybody. So why is it? Because a well-crafted question is very easy to break the ice. For example, if I want to strike a conversation with someone, the first thing I ask is, what's your name? You ask a question to somebody and it becomes easy to break the ice. It generates discussion. It gives you new insights on multiple, topics. Most importantly, when you have a lot of things to deliver, it's like more or less a text. You're providing a summary in the form of a question and an answer, which we are trained to as students. Instead of reading the entire textbook, we are always used to reading the question and answer, which teacher marks us at the end of the summary. And obviously it serves the purpose of evaluation. It's a cornerstone tool used for evaluation. So using a complex set of questions is what is called quiz, and it can be a wonderful pedagogy tool. So it tests multiple dimensions, first of which is knowledge or memory. For example, asking a person to list, name, or identify is testing the knowledge or their memory. You can also test their comprehension or understanding by asking them to summarize. This is what most commonly we use when we really have to cross-check or verify the fact that our patient has really understood what we're talking to them. It can be used for analysis. For example, you can deduce, you can compare, you can try to organize. Lastly, it can also be testing the application side of your, the brain, where you try to solve a problem, you try to illustrate something, or you try to calculate something. But there are also pitfalls to it, and there are also goods to it. So a question can either evaluate the subject matter, or it can test about the environmental matter, or it can test about the reader's personal response. Because when you craft a question, the subjective understanding of a question becomes the reader based or the participant based. So based on this, we have two types of question. One is an enriched question, which might target either of the component. For example, me testing the memory, which is subject matter, and also testing the person's understanding or application is a conjugation of both. For example, if they are Venn diagrams, if this is A and if this is A, this is B, A intersection B could be an enriched question, but A intersection B intersection C, a question which tests all the three matters, is actually called a dense question. That's what is called a dense quiz. So the best part is that you can use audiovisual aids, you can use it the classical pen paper method, or you have a lot of audio response system. For example, one such like Kahoot app, then you have the Google Forms app, then you have the poll option which happens in Zoom. So multiple designs can be used and multiple modes can be utilized in one single pedagogy. It can also serve as an evaluation tool, and the best part is you can also get a pre and a post test analysis and also receive feedbacks. So what are the advantages of quiz? So it can be blended easily with any of the other pedagogies. It is one of the easiest teaching methods, and it can be put on combination with any of the other pedagogies that we have been learning so far. Second, it gives participants a hold. They also have the power of expression. For example, as in when we saw the results popping up, we realized that yes, there's a power of expression of the participant and they get interested. It reflects the background of the participant and tells us where they're strong, where they're weak. So that is why when you understand where they're strong or where they're weak, it will also help you in designing the program effectively, in trying to design the program in such a way that you target the audience and you give them what they want. Like I think that's what Indu ma'am also did. When we joined the program, she gave us a questionnaire. We all filled it. Based on our understanding, she evaluated, and then she designed the 10 modules of the program the way we actually wanted, so that she catered everybody's needs. Next, moving on, it is a comprehensive delivery system. I think, as I rightly told you, I remember one of my OBG teachers, fibroid couldn't have been more interesting because she made just 10 questions and she explained entire fibroid in just those 10 questions. So you will, and the way it actually kindles your memory also, it stays in your memory, that form of a delivery. So comprehensive delivery is possible. It gives a flow to the content. For example, the way we design the slides, you can decide the questions, you can rate the questions, and you can scale them and form a coherence in the flow of content. These are what commonly the edutech platforms use in the form of QBank modules. If you look at any of the QBank modules that these edutech platforms have, like for example, Marrow, or you have Unacademy, you have this Byju's, all of these are actually the form of coherent content in the form of a question. So each question and explanation makes a flow to the topic. And lastly, asking the question at the end can always help you take good take-home messages. So what are the disadvantages? It all depends on the skill of the presenter. How far you're good, how far you're not good, how far you're designing the question. It can be time consuming. It can mar the class atmosphere at times because too much of a question can be intimidating and not reassuring. And again, it can show authoritative behavior also. So if it's misunderstood, it could mar the class atmosphere. Lastly, when you are dealing with complex timid participants who feel very bad or who don't want to participate, or with seniors who think they know something, but at the end they don't actually score good, it can backfire on you. What are the practical concerns while designing a quiz is you need to phrasing and clarity. How you phrase the question is very important. Some of them might not understand. So it is the duty of the trainer to rephrase or provide clarity on such questions that people don't understand. So how do you know whether they understood the question or not? Is by checking the ambient response. Is it intimidating? Is it reassuring? Is it unwelcoming? Do you think it is psychologically safe to ask such a question? You need to take all of this into practical concerns before designing the quiz. Next, use of non-verbal communication is the pillar of the host. It's like that invigilator who walks inside your exam hall and tries to give you a good feeling even though the question paper is horrible. So the question paper, despite being horrible, if there's a use of non-verbal communication, it forms a pillar for the host. Next, you always have to sequence and balance the question. It has to move from a low order to an increasing order. It cannot, be haphazard. It has to have a flow. So what's the ideal time for each question? Generally, research says it's 20 seconds, but there could be wait time, there could be lapse time, and depending on your cohort, you need to design and frame, how much time you want to give for each question. And never try to answer your own question, because then that's self-defeating. Can we use pimping questions? No. So what are these pimping questions? So these are actually questions which show your superlative authority. This shows your authoritative behavior. Whenever you're dealing with students or whenever you're dealing with young people, or for that matter person of any cadre, never show your superlative authority. Always try to maintain this humility while designing, using quiz as a pedagogy, that you're one among them, you're one among the cohort. So I think that always is a strength and is helpful. And never ask open-ended questions, because they defeat the purpose of a quiz. Then that becomes an essay or a monologue. So these are my references. Thank you.
So thank you, Gaurang. I think you introduced us to a new pedagogy. I think for many of us, at least for me, I would say I haven't used it earlier. So for me, it was a new learning. And it was a wonderful presentation. Of course, you really got everybody on board and everybody got excited in playing and participating. I think Dr. Ila does not know that she was the one who topped, because she logged out when, when you were announcing the results.
I lost the connection actually.
I know.
Congratulations, Ila ma'am. Like, if ever I get a chance, at least one coffee is on me as just token of
My
prize.
grade is quite low. Many times in the past.
So I think the second presentation, I think we can have next time, because it's already very late for all of you. And even the feedback form, I'm going to share in the group, not here, but please complete the feedback form by tomorrow. And that feedback is not for Gaurang's presentation, but for breaking bad news. Remember that. Yeah.
But any feedback from you also, yeah. Everybody, please let me know.
Very enriching, Gaurang. It's entirely new and it seems so exciting. And I think the zest in life lies in learning something new every day.
Absolutely.
Something new.
Thank you, ma'am. Thank you so much.
Because just to tell you, Gaurang, my daughter is your age only. She also had her entrance today. The way you
Yes, ma'am. I think we have a common friend. There was one day when I was discussing this course with one of my friends. I think you should be knowing Ria Kurumude. She's my best friend, and we were colleagues at Maro. And I think Ria and your daughter are classmates and the next adjacent roll numbers.
I don't know. Fingers crossed for both my children. You as well as all the children who are praying that they may get.
Thank you so much, ma'am. Means a lot.
I'm admiring. You are into intensive while she's partying out with her friend at home. And here you are into an intensive mode. Admiration, all admiration to you. For you.
Thank you, ma'am. Thank you.
So I think we'll close it here if everybody's okay with it. Thank you so much for adjusting the timing and being up so late. I know you're all very tired and exhausted by the end of the day.
Actually, I wanted to tell that, yes, ma'am. Thank you all for adjusting. It was because of me that you guys agreed to do it. I had the first class. It got over only by 8:15, 8:20. So thanks a ton. Means a lot. Thank you.
Thank you. Thank